Good evening, everyone. Thank you for being here for the webinar. I welcome you on behalf of NAFEL Academy to the webinar on the management of treatment of diabetes mellitus. This has been presented by Dr. Pandya. Pandya is renowned specialist in advanced internal medicine, focusing on acute and general medicine. She also focuses on chronic disease management. In this session, Dr. Pandya will emphasize on the critical importance of early detection through widespread health screening for diabetes mellitus. She will provide medical practitioners with updated insight into effective management of diabetes mellitus, ensuring they are equipped with latest knowledge and strategies to enhance patient care. So with this, I hand over to Dr. Pandya. Dr. Pandya, can you put your presentation onto the screen? I'll stop the share. You can share your screen, Dr. Pandya. Thank you. We can see your screen.
Thank you. So thank you, Dr. Jayes, for your kind introduction. And thank you, everyone, for joining today's webinar. This is the evening time, your precious family time, and you are spending 1 hour with me. So thank you very much. Good evening to everyone. And without any delay, we will start our presentation. So as Dr. Jayes mentioned that I'm going to go into the detail of the DM management. So before I go into the DM management, I just want to focus on the primary prevention. And in the, we have the, so usually we have a huge emphasis on the preventive healthcare, particularly in the primary healthcare and the primary health settings. So why we are mainly focusing on the preventive healthcare? Just because we want to detect the disease early and reduce the complication as much as we can. And usually for the adults, our focus will be on the cancer, chronic disease, cardiovascular disease, dementia, fall. Apart from that, what is the next thing that we should do? 1 minute. I'm just trying to go to the next slide. Okay, so usually when we are looking for the quality of the healthcare, we are looking at the two things. One is the appropriate treatment of the current illness and appropriate preventive care to attempt the future health decline or the functional decline, which also includes the complication. Even though patients are asymptomatic, we are supposed to treat them, then which can reduce the future burden of the disease. And our healthcare of the Singapore is ranked 6th best in the world by the World Health Organization. So in the preventive care, usually we can divide preventive care into the primary, secondary, and the tertiary prevention. And the diabetes mellitus, which is we call it normally DM, will come into the secondary and the tertiary prevention. So in the Singapore, our government has announced war against the diabetes. We are seeing rise in the diabetes, even the younger adult less than 40 years. And it is also affecting 400,000 people in Singapore. And our projection is that there may be around 1 million people with a diabetes in Singapore by 2015. And that's why the diabetes management is very, very important. And there is CNN news focused on the diabetes, that how
diabetes is affecting more young people and not just older adults. Doctors here in Singapore are seeing more patients, some as young as 30 years old, having the disease. Sherlyn Sia finds out there are two key reasons: modern lifestyle habits and greater awareness of early screening.
So it is also highlighted in the news and the recurrent media as well as in our recent MOH, Ministry of the Health guidelines and the ACE guideline, which is also it is also by the government of the Singapore. So when the patient has a diabetes, they are not only at the risk of the one chronic disease, they are also at risk of the other chronic disease. So they are more likely to have the high blood pressure, and that risk is nearly double for the blood pressure. And Singapore is the sixth leading cause of mortality, and it has a huge burden in our country. Around 10% of the resident has diabetes who are aged 18 to 74 years of age. Diabetes is defined as one of the chronic disease by Ministry of Health, and these are the chronic disease included in our Ministry of Health and diabetes is one of them. So why we are focusing on the more on the chronic disease, because the chronic disease can lead to the cardiovascular disease as well, and they are the risk factor for different cardiovascular health problems such as MI, ischemic heart disease, heart failure, or the stroke, or even it can lead to the dementia in the future. So the possible complication, we are all aware that it can lead to the macrovascular, microvascular complication. But Singapore is a country with the highest incidence of the diabetes-related end-stage renal failure and the amputation worldwide, which makes the government to declare a war against diabetes in 2016. So these are the DM complications, and the underlying pathophysiological mechanism is the hyperglycemia, insulin resistant, causing the immune dysfunction. Along that side, dyslipidemia and hypertension may also play a role, and it will cause a microvascular and the macrovascular damage. We are always aware of the microvascular and the macrovascular complication, which I will go in detail a little bit later on. But there are a lot of oral complications as well related to diabetes that sometimes we forget and we don't think of that. So this is a pathophysiological mechanism why diabetes lead to the chronic complications. And microvascular complications are usually the retinopathy, nephropathy, neuropathy, or the diabetic foot. And the macrovascular complications are the coronary artery disease, cerebrovascular disease, and the peripheral artery disease. And in the oral complication, there are many like periodontitis, caries, dry mouth, oral ulcer, taste disturbances, etc. So I will just little bit focus more on the oral complication, because when I was preparing for this slide, I was so surprised that it is so common, and probably it is the new insight for me when I was preparing this presentation. So I would just like to share with you. So periodontitis, this is the pictures of the periodontitis, and it's very common. Diabetes lead to the alveolar bone loss and the connective tissue damage as well, which can lead to the periodontitis. It is a chronic disease, and the patient with the diabetes has higher incidence of it. And when we don't look at it, particularly for the oral elderly population, they have their food intake affected by it. It can also lead to their a lot of intake problem, and it can contribute to the frailty in the future. So it's very important in our elderly group. It can also lead to even the peri-implantitis. So if the patient has implant, they can also get it inflamed, and then they might get dislodged or has some problem with the implant. The caries is one of the common thing. We know that the diabetes can increase the risk of the infection, and probably it is just the immune dysfunction that it can lead to, which can cause this problem. 1 minute, I don't know how to get rid of it. Okay. So the so other complication can be the dry mouth due to hyposalivation, and it can lead to the it is more particularly important in the older people, where they can have the polypharmacy, and some of the pharmacy also has the side effect of the gerostomia, and which can reduce the salivary flow rate as well, contributing to their dry mouth as well. Although there is lack of longitudinal studies, but we have seen quite frequent in the diabetes patient. Is the candidiasis is the other, because it can increases the opportunistic infection and can lead to the recurrent fungal infection for the mouth. It can also lead to the precancerous lesion and the oral cancer. Although we have seen it is more, the incidents are higher in the diabetic patient, but we are not aware of any associated pathophysiologic pathway, and the research is still pending, and there is lack of strong evidence behind it. But this is just the association has been seen in the epidemiological study, and because we don't know what is the underlying pathophysiological mechanism, so prevention and the treatment are still lacking for this part. Uh, Temporomandibular joint dysfunction. Quite a lot of time patient does complain that they have the pain during mastication, or they have the mandible joint pain, they have lax mandible. This is quite often we encounter in the clinical practice, but we don't think the diabetes is as an underlying cause. Again, it is part of partially because of the connective tissue damage, and partially because of the peripheral diabetic neuropathy leading to this complication. Taste disturbances is another one which diabetes can lead to, and the burning mouth syndrome, which is the chronic pain of the intraoral soft tissue, and the diabetes can lead to it from the peripheral neuropathic mechanism. So these are the few complications that we need to be aware in the diabetic population, which were relatively new for me. As I told that these are some of them are having the strong research correlation is still pending. Longitudinal studies are still pending, but they have seen the incidence are higher in this population. We all know that the retinopathy screens are important. Neuropathy screen as well as a nephropathy screen is important, and diabetic foot screen we should do also routinely, which can help us to get the early detection of the underlying problem and treat the patient, so which can reduce down the number of the amputation that the diabetic patients are suffering from, which can lead to a lot of disability and the game changer for their life for many patients. For the cardiovascular macrovascular complications, coronary artery disease we know is quite common. Some of them are also having no symptoms, or they don't have any angina or the typical chest pain. We all know that the stroke and the peripheral artery disease, the diabetes is one of the risk factor. So what usually we do when we see the diabetic patient, usually we think of the complication and we have to think what we are going to do for the complication. So for the diabetic retinopathy, we do the diabetic retinopathy screen for the urine albumin creatinine ratio, as well as creatinine in the renal panel. And for the neuropathy and the diabetic foot, we usually do is the diabetic foot screening. So in the macrovascular complication, it is not routine practice to do the 12-lead ECG, but some of us do at the periodic interval. That periodic interval is also not defined yet. It's just on the individual practice basis, and it depends on the also patient's underlying comorbidities and the underlying symptoms and the risk factors. For the peripheral arterial disease, ankle brachial index can help, and this is a part of the diabetic foot screening. So this is included in that. Now coming to the diagnosis of the diabetes mellitus. So usually in Singapore, our government has not included the HbA1c in the diagnosis of the diabetes in the initial guidelines, and they have updated it later on, which I'm going to go through. So first is the patient who are asymptomatic, how we diagnose for them to have the diabetes. So usually is based on the fasting plasma glucose, random glucose, or the oral glucose tolerance test. And we all know that cutoff is a 7 millimole per liter for the diabetes fasting glucose, and for the oral glucose tolerance or the random glucose, it is 11 more than equal to 11.1 millimole per liter. So we have to just make sure that the fasting is done for at least 8 hours without any caloric intake. So patient can have the sips of water if they feel thirsty, but they should not eat or drink anything except the plain water. If the patient are symptomatic, or the patient is having the diabetic crisis, then random glucose 11.1 millimole per liter single test is confirmatory for the diabetes. For the symptoms, why the common symptoms are the thirst, polyuria, weight loss, and the blurry vision. And the diabetic crisis, we know that it's a diabetic ketoacidosis and the hypersmolar hyperglycemic state. So these are the two complications. Once they have one single count, hypo count will determine that they have the diabetes. So this is the international guideline. This is the American guidelines, which has included the HbA1c in the diagnosis of the diabetes, and their cutoff is more than equal to 6.5%. And other thing we have to emphasize that the HbA1c, how it is done in the laboratory is very important, because so far American guideline and our local guideline has certified these two techniques of the NGSP and the DCCT assay as a more accurate for the HbA1c validity. Other two are the similar. The other two diabetes diagnosis criteria is the fasting glucose and 2-hour oral glucose tolerance test. We call it OGTT. So now coming to the HbA1c, as I previously mentioned, HbA1c was not initially included in the MOH guideline for the diagnosis. Now in the updated guidelines, government has included the HbA1c, but our cutoff is different than the American guidelines. So our cutoff is a 7% for the Asian population for the diagnosis of the diabetes as well as to start the treatment. And for the Asian people in our local population, if the HbA1c is 6.5 to 7%, then government has suggested to do the one more test to confirm the diagnosis of diabetes rather than just relying on the HbA1c. So that one we need to just take care into our clinical practice. So this is the algorithm. Sorry, I don't know how to get rid of it, but this is the algorithm that if we suspect the patient has DM, but patient has any hyperglycemia with acute metabolic decompensation, which is a diabetic crisis, then even single diagnosis can confirm the diabetes. If patient has the major plasma glucose and any of this number comes with typical symptoms, then one number with the typical symptoms confirm diagnosis. But if only these numbers are there and patient has no symptoms, then we have to do one more times our blood test. It can be the fasting glucose, it can be the random glucose, or it can be the oral glucose tolerance test to confirm the diagnosis of the diabetes. So we need the two blood tests if the patients are asymptomatic to confirm the diagnosis of diabetes. There are also possibilities that, okay, so I just go on to the impaired fasting glucose, and I go to the different scenarios. So in the impaired fasting glucose, also the patient has a fasting glucose between 6 to 7. And we need to, if the patient has impaired fasting glucose, they recommend to do the oral glucose tolerance test. And if the oral glucose tolerance test after 2 hours is less than equal to 7.8 millimole, then it is impaired fasting glucose. If it is between 7.8 to 11, then it is impaired glucose tolerance. But if it is 11.1 or more, then it is confirmatory for the diabetes. But sometimes we also encounter that patient has fasting glucose, patient has HbA1c, and we don't know what to do with this discordant test results. This is a occasionally coming scenario in the clinical situation. So our government has suggested that the whichever test is abnormal, is above the diagnostic cut point, that one has to be repeated. So if the fasting glucose is abnormal, then we need to do fasting glucose. And if the OGTT is abnormal, then need to repeat the OGTT. If patient second time we do the abnormal test, which was above the diagnostic cut point, and it comes back as a normal, then this patient needs to be followed up quite closely. And instead of yearly follow-up or the yearly screening, this patient needs the screening around 6 monthly to find out whether they have the underlying disease or not. So these HbA1c quite often are documented in the two way. One is percentage, one is millimole. So this is a graph which shows that what is the percentage equal to what is the millimole. And if we have the laboratory which does not mention both values, then this graph is useful for us to find out whichever the value we are familiar with. So POCT, HbA1c, we do monitor quite often in our clinical practice to avoid the repeated blood taking from the patient. So this POCT, we have to be careful because it cannot follow the DCCT or the IFPP guidelines or the reference method for the HbA1c, and we have to go by the patient symptoms, as well as if patient has self-monitoring of the blood glucose, we should have a look at it. If the HbA1c, POCT, HbA1c, and the self-monitoring of the blood glucose is not matching, then we should go for the proper blood testing for the HbA1c. When we look at the HbA1c, we need to interpret cautiously, because there are certain conditions which can make it go up high, and there are certain conditions which can make it falsely go down. So the falsely low can be possible in hemolytic anemia, chronic renal failure, or the recovery from the acute blood loss. And the falsely higher level is possible in the iron deficiency anemia. Other thing we need to take care is that hemoglobinopathy, which is common in the South East Asia people. We see the thalassemia patient. These hemoglobinopathies do interact with our HbA1c, the assay. And when the patient has a thalassemia, we need to interpret the HbA1c properly and see, if possible, we can also ask them for the symptoms, ask them for their self-monitoring of the blood glucose, which can give the better idea. So coming to the treatment, so what can be our treatment goal? So treatment goal is, we know that achieving the glycemic control is a treatment goal, but also the reduction of the cardiovascular risk or the complications are equally important. And we all know that diabetes is a multidisciplinary approach. And in the multidisciplinary approach, it includes the non-pharmacological as well as the pharmacological measures. In the non-pharmacological measures, we know our healthy plate by the government, which is half is with the fruits and vegetable, 1/4 is whole grain, and 1/4 is protein. The BMI, we have to follow the Asian BMI range, which is 18.5 to 22.9, which is different than the Western BMI range for the normal BMI. Exercise regularly, so it's just moderate intensity exercise, 30 minutes 5 times per week, so total 150 minutes can be is encouraged or advisable. And if patient don't have enough time to do the 150 minute of the moderate intensity activity, then they can do the 20 minute of the vigorous intensity activity 3 or more times a week. Limiting alcohol, 1 alcohol drink for female and 2 for male per day. Quitting smoking, and the mental well-being. In the pharmacological treatment, we have the few options, which I will go a little bit later on. So for the treatment wise, we have to think, okay, once the patient comes, first time diagnosis, what I'm going to do? Am I going to prescribe him the monotherapy, dual therapy, or the insulin therapy? So it also depends on the what is their blood test result. And if the HbA1c less than 7%, then you can think of the lifestyle modification, and let them follow up in the 3 months time and see whether it is effective in keeping their HbA1c under control. But if the HbA1c, in spite of starting patient on the metformin, which is a first-line monotherapy for the diabetes, and HbA1c is 1.5 times or more above the target, then this patient need a dual therapy. And insulin therapy, when we cannot control their HbA1c with the oral anti-diabetic medications, that's where they need the insulin therapy. Quite a lot of us has that impression that the gliptin, sitagliptin, linagliptin, and the DPP4 inhibitor, which is the gliptins, and the SGLT2 inhibitor, which is the dapagliflozin. Such medication, they do not do the hypoglycemia, but there are recent meta-analysis that these medications, when combined with the metformin, can cause the hypoglycemia. And I have encountered a patient recently with this combination having the hypoglycemia. So this is a new, and it has been emphasized in our guidelines as well. So we need to ask them and look for this side effect when the patient are in the combination with the metformin with DPP4 or the SGLT2 inhibitor. So starting our initial therapy is obviously the lifestyle change. It can help to reduce HbA1c by 1 to 2%. Bequinide, which is the metformin, which is our first line medication for the diabetes, which also again helps to keep the diabetes control and HbA1c reduction 1 to 2%. It can also cause the weight loss, but quite a lot of time it can also has a GI side effect. And when the GI side effects are there, then we advise to start with the slow dose and increase the dose gradually. Other thing we can do is ask them to take with the food or after food, or sometimes the extended release formation of the metformin helps to reduce down the GI side effects, and we can see how they're doing. Other thing we need to take note that we need to look into the EGFR of the patient, whoever are on the metformin, that it is contraindicated when the EGFR is less than 30 ml per minute. The next alternative medications we have the sulfonamide. We are all aware of it. Again, the HbA1c reduction is similar to the metformin. It's rapidly effective, but it has the risk of the hypoglycemia. Glitazone, which is a pioglitazone, we don't use that frequently nowadays, but it is still in our guidelines as a additional therapy or the alternative therapy, and it can reduce the HbA1c 0.5 to 1.4%. The only thing that it increases the risk of the heart failure and it causes a fluid retention. So it is contraindicated in the patient who has the heart failure. But the good side that it can improve the lipid profile, reduce the MI and the stroke reduction. This two class of drug we are not using nowadays, so I'm not going to go in the detail. But acarbose is an alternative medication for the pre-diabetes, which I will come to that later on. Other alternative therapies are the gliptin and the SGLT2 inhibitors. The reduction in the HbA1c is similar for the both group. SGLT2 inhibitor can cause weight loss, and the gliptins are neutral for the weight. But gliptin, particularly jaxagliptin, has increased risk of the heart failure. They are expensive, and they have very significant cardiovascular risk reduction. So nowadays, more and more people are using quite often in the patient who has a diabetes, and sometimes the patient who does not have diabetes, for the cardiovascular protection and the renal protection, it has been used in the clinical practice. For the SGLT2 inhibitor, we need to inform patient that they are at the risk of the increased fungal infection, particularly genital fungal infection, as well as a recurrent UTI. And we should inform them about that. Once they develop it, they should inform us so we can do the dose reduction or the change the medication accordingly. The insulin, we are all aware that they are the human insulin analog or the human insulin. The HbA1c reduction is very good with the insulin, is 1.5 to 3.5%. It's rapidly effective. It improves the lipid profile, but it can cause hypoglycemia and the weight gain, and it requires home glucose monitoring. So always in our ACE guideline, there is a lot emphasis on the personalized management for the patient, and discuss with the patient each and every step what are the options available and what are the side effects, what are the advantage, and how they want to go ahead with the treatment, or they still want to stick to the alternate treatment. So it is a great emphasis on the personalized management of the treatment in our ACE guidelines. Other alternatives are GLP-1 agonists. They are mainly injectable, only the oral is semaglutide. It can be the daily dose or the weekly dose, depends on the which medications we have. It can also can lead to the decent HbA1c reduction with the 0.5 to 0.2%. It can also cause a weight loss, but it's very expensive. There are dual component GLP-1 and the GIP receptor agonists, which is again 2% reduction in the HbA1c and can lead to the weight loss as well. Again, it is injectable and expensive. So this is our guidelines by the MOH that how should we go for the diabetes. So if the patient has HbA1c less than 7%, then we just ask them for the lifestyle changes and the non-pharmacological management. Metformin monotherapy is an option. Again, the discussion with the patient is preferred and decide based on the share decision making with the patient. If the HbA1c is 7.7 to 9%, then monotherapy with the metformin, and alternative therapy can be sulfonylurea, DPP4 inhibitors, or the thiazolidinedione. Dual therapy may be appropriate in this group of patients where the HbA1c is between 7 to 9%. Every step, whatever is HbA1c, we need to emphasize on the lifestyle modification and optimization in the physical activity and the diet. And if the patient has the HbA1c more than 9%, then insulin therapy is recommended. And consider insulin the first line therapy if the patient has a diabetic crisis or the patient has a severely uncontrolled diabetes or the symptoms of the diabetes. So if patient is seeing us first time and we don't have the HbA1c, what should we do? So the government has suggested that if the random glucose more than 15 millimole per liter or the fasting glucose more than 10 millimole per liter, then we can go ahead and start the treatment. And again, we can start with the first line therapy and see the response and evaluate the further necessary treatment needed for the patient. More and more guidelines are coming up with a lot of cardiovascular benefit of the GLP-1 receptor agonists as well as the SGLT2 inhibitors. And our government was also discussing in the ACE guideline that whether we should include after metformin, this is the alternative treatment for our diabetic patient, but still it is under discussion. Still, major guidelines are sticking with the first line metformin and the sulfonylurea traditional way. But some of the guidelines has adopted even the monotherapy for the GLP-1 receptor agonist and the SGLT2, but it's only few guidelines. And this is the algorithm, which are the patients should be on the GLP-1 receptor agonist or the SGLT2 inhibitor. And the patient who are having the type 2 diabetes and taking metformin, but the HbA1c is less than 9%, then have to think what is their EGFR. If EGFR is normal, then whether they can have the established cardiovascular disease or the CKD, then go for the GLP-1. But if no, and if they are at risk of the heart failure, then go for the SGLT2. If not risk of heart failure, but has the proteinuria or the albuminuria, go with the SGLT2 inhibitor again. And if they have the atherosclerotic cardiovascular disease high, then go for the GLP-1 receptor agonist. And these are the certain contraindication that we need to be aware for the GLP-1 receptor agonist and the SGLT2 inhibitor. So this patient should not be started on such treatment. They have not mentioned here, but the severe hepatic impairment are contraindication of both these medications, and it is mentioned in our Singapore ACE guidelines. So as discussed, the insulin should be started if the patient HbA1c is not under control with the oral anti-diabetic medication. And insulin can be started usually by the basal insulin. It can be the intermediate or the long-acting insulin. And when the patient start on the insulin, we need to review the concomitant glucose-lowering agents. So mainly the sulfonylurea, which can cause significant hypoglycemia with the insulin. So if the patient is on the sulfonylurea and we are starting them on the insulin, we need to stop the sulfonylurea. But we can continue with the DPP4 or the SGLT2 and the metformin with the insulin. And we have to educate them for the hypoglycemia symptoms and the management of the hypoglycemia. So these are the few insulin combinations available in Singapore, and what are the starting dose for the insulin. We should start and monitor the patient accordingly. I'm not going more in detail for the insulin because it's a very long talk, and again it takes another CME talk to talk about that. So I will just I have included a couple of slides only. So now follow-up, we know that chronic patient need the every 3 months follow-up. If they have their target not matched for achieving their HbA1c, or they have unstable glycemic control, there is recent adjustment in the therapy or the intensive insulin therapy. And every 6 months, if they are doing well and they have achieved their target. So what is the target for the glycemic control? So target should be individualized. So previously we have the optimal, adequate, that type of category for the glycemic control, which has been removed in the updated guidelines. They says the target of the glycemic control should be individualized. I will touch base on this a little bit later on. But here in general, type 1 or type 2 diabetes, non-pregnant adult, HbA1c less than 7% is acceptable. Apart from HbA1c, there are 2 to 3 glycemic control. They have mentioned that pre-meal glucose should be 4 to 7, and the 2-hour post-meal glucose should be less than 10 for the glycemic control. And the self-monitoring of the blood glucose will be required in some patient, particularly the patient, if patient is having the type, any type of diabetes and on insulin, patient who is using the sulfonylurea, and the patient who are pregnant who has a diabetes, and those who is experiencing the acute illness and who fail to achieve their glycemic control, which can help us to titrate the dose of medication and start medication accordingly. So this is the HbA1c. So in general, target is 7%, but there are we have to look into the individual patient to decide for the target. So if the patient is young and he has early stage of microvascular complication, we can consider to bring down the HbA1c to less than equal to 6.5%. But if the patient is old and has long duration of disease and has already established the microvascular and the macrovascular complication, then the HbA1c can be a little bit liberal and the target can be less than 8. So usually we say age divided by 10. So if it is 77, 88. It can also help to rough guide for the diabetes according to age of the patient. So what we are supposed to monitor during each visit of the diabetic patient. So again, is the BMI. And if they are smoking, advice for smoking cessation, also advice for the BMI target. What is the BMI target for them? Blood pressure should be measured at every visit, and their blood pressure target should be less than 130/80 millimeter of mercury. So they have a stricter blood pressure control. Their lipid LDL should be between 1.4 to 1.8 millimole per liter as well, because they are at a high risk of the cardiovascular risk. They should get the annual diabetic retinopathy screening, annual diabetic foot screening. If any of this is abnormal, need to refer to the ophthalmologist or the vascular surgeon respectively. If they have the albuminuria, microalbuminuria, then have to start on the aceviter and ARB and control their diabetes, high blood pressure, and the high cholesterol target and see whether it is coming down. Once they reach to CKD stage 3B, that's why they need the referral to the nephrologist. Otherwise, you can control their risk factor meanwhile. Apart from that, other laboratory tests they should be going is our simple GFU. And vitamin B12 is very, very important for the patient who is on the metformin. Particularly, metformin can lead to vitamin B12 deficiency. And it is emphasized in the American guidelines that this patient should be on the vitamin B12 replacement if they have the low vitamin B12. So it's very important to check on the for the patient who are on the metformin. So this is the that was the guideline from our local guidelines. This is the American guidelines, which says that they even they recommend the dental examination, annual dental review for the dental complication, but it is not included in our local guidelines yet. So we can just go by the symptoms, or we can just do the oral examination. If it is present, then we should recommend them for the dentist review. For the cardiovascular prevention, cardiovascular disease prevention, if they have already established, then you can give the secondary prevention. But for the primary prevention, you have to calculate their atherosclerotic risk factor. And if the 10-year is more than 10%, then aspirin is recommended, but the evidence is weak. And we have to balance, particularly in our local population, the bleeding risk is high with aspirin. So we have to balance the cardiovascular benefit versus the bleeding risk, and always need to discuss with the patient for the shared decision making. But if the cardiovascular risk is less than 10%, then usually the aspirin is not recommended. And this is the calculator, which is the atherosclerotic cardiovascular calculator. So I have just put the link here. but it is not recommended in our local guidelines. Vaccination is again not included in our local guidelines, but is very important for the diabetic patient. So they should be having the up-to-date pneumococcal vaccination, annual influenza vaccination, and the COVID vaccination as per local guidelines. They are considered medically vulnerable patient for the high risk for the COVID. So we need to follow our local emerged guideline for the COVID vaccination for such patients. And they should be also receiving the hepatitis B 3 doses if they are not immune to it. This is the sleep disorder and the type 2 diabetes. It's very, very common sleep disorder with a diabetes patient, particularly obstructive sleep apnea. Obstructive sleep apnea can lead to insulin resistance and increase the risk for the diabetes. So this patient should be screened for the sleep disorder and the obstructive sleep apnea. Quite a lot of patients are having underlying obstructive sleep apnea, but they are not diagnosed, and they should be treated concurrently with both conditions, which can give them optimal cardiovascular benefit for the future. So now question comes when we should refer to a particular specialist. So when the patient has difficulty achieving glycemic control despite the appropriate management, or the patient who are getting recurrent frequent hypoglycemia regardless of HbA1c target, and the patient who are having diabetic crisis like diabetic ketoacidosis or the hyperosmolar hyperglycemic state, and the patient who has CKD stage 3B or higher need to refer to the nephrologist. Patient with a foot ulceration, gangrene, or the severe peripheral arterial disease has to refer to the vascular surgeon, and the ophthalmologist if they have the diabetic retinopathy. So these are the overall care of the diabetic patients. So quite often included the peri-operative care, because Nafil has many dental surgeons working, and it might be useful to them. While we are worried for the diabetes care in the peri-operative period is mainly because diabetes can increase the risk for the infection, cardiovascular event, and the poor wound healing. And we need to just control the diabetes very well, and HbA1c should be less than 8.5% if we have the time. If we don't have the time, then the we have to just go by their sugar level and monitor their sugar peri-operatively. They should be also having the ECG and the creatinine, and the goal is just to prevent the hypoglycemia or the hyperglycemia and the diabetic ketoacidosis, and maintain their fluid and electrolyte balance. So in view of time, I will just go very fast with these slides that how should we doing, and what are the, if they are on insulin, cut down the insulin dose. Some of the medication like GLP-1 agonists, you have to you can continue. Other oral diabetic medication can continue until the day of surgery, but the SGLT2 inhibitor has to stop 3 to 4 days before surgery because it can lead to euglycemic diabetic ketoacidosis. And these are the hypocount monitoring intraoperatively and the hypocount target for the patient, and how should we give the sliding scale insulin intraoperatively. And the postoperatively, dreaming means making them to eat, drink, and mobilize early is the cornerstone for the diabetic postoperative care. And this helps them to restore their usual diabetic regimen as soon as possible. So should I go to the pre-diabetes? Are you guys okay for me to go through the pre-diabetes? It's just 3-4 slides.
Yes, doctor, you can continue with this. Thank you.
Thank you. So the pre-diabetes again is very common. We see in our routine clinical practice is the fasting glucose between 6 to 7%. And there are certain guidelines how should we deal with this type of people. And certain lifestyle measurement can help them to delay or prevent the onset of the diabetes in such individual. So this is our local guidelines. They have said that if our fasting glucose between 6.1 to 6.9 millimole per liter, or the 2-hour plasma glucose less than 7.8 millimole liter, then they classify as the impaired fasting glucose and the impaired glucose tolerance. So these both conditions are the pre-diabetes label in our local guidelines. And again, the glycated hemoglobin is not part of our pre-diabetic definition yet. And any patient who has impaired fasting glucose should go for the oral glucose tolerance test as per our local guidelines. This is the American guidelines where the HbA1c target is more stringent, is 5.7 to 6.4. There even the fasting glucose is more stringent, 5.6 to 6.9. But the oral glucose tolerance is similar to us. So these are the lifestyle measures that they have to do. The portion of healthy plate, avoid sweetened beverage in the food, limit alcohol intake and increase physical activity. So this physical activity we should emphasize patients. So these are the activities such as brisk walking, leisure cycle, not the leisure walking, brisk walking, swimming, jogging, cycling, and the vigorous exercise can reduce down the little bit of duration, then can help them. And if they cannot be exercise every day, no problem, but they should avoid more than 2 consecutive days without exercise and engage patients in the exercise all the visit. There are some pharmacological treatments available. So apart from the lifestyle and the diet change, they have certain pharmacological options. And these options, if we can start them on the metformin 250 milligram BD, maximum up to 850 milligram BD. And if they develop the GI side effect, we can start them on the extended release formulation and see how it goes. If the patient still cannot tolerate the metformin, then they have the option of the acarbose. Particularly, it can help to bring down the postprandial glucose. And certain individuals are at the higher risk of getting the diabetes, such particularly the people who are overweight with the BMI more than equal to 23 kg per meter square, the people who are younger than 60 years of age, and the woman who has the history of the gestational diabetes. So these are the people will benefit from the lifestyle change as well as the medication as well. So my majority of the reference are taken from the local guidelines, and these are the local guidelines, which is the AIDS, which is recently updated in the May 2023. Here is the very nice clinical information guidelines. So you have to just scan this QR code and the all guidelines will appear. And for the clinicians, these are the information is coming in the scanning of this QR code. And in the clinical practice, what are the government listed as GLT2 inhibitors and which are the subsidized and which are not subsidized. So which is quite useful for the clinician. There is another one. This is something like this information coming for the clinical information for clinician. And this is for the patient side, how the patient will look into it. And this is the information leaflet for the patient. We have to just print out and ask the patient just to read. These are, if the patients are IT friendly, we can just ask them to do the QR code and all the information will come on their handphone. And what they will say is the patient education aid in the what is a healthy lifestyle and less with the diabetes. These are the things will appear for the patient education wise. Health Hub has also good information for the diabetes for the patients. And what are the pre-diabetes lifestyle intervention? This is a QR code patient can scan and they can follow this advice. And this is just the brief video of the patient education that they have made. For this video in view of time, but it's really very good information for the patient there. and we can play in our clinic, all the clinic, which can also get our diabetic patient on the regular follow-up, gives information to them, family members and the patient, and it will be very, very useful to them. So I'm ending my presentation here. Once again, thank you very much. And I'm ready to take any question.
Yes. So thank you, doctor, for that insightful session. We have a question where the question is in the Q&A session. Says, with the growing global emphasis on the personalized medicine, what would you best suggest to address the challenge of applying genetics and biomarkers data to tailor treatments for type 2 diabetes mellitus complications? Additionally, because the use of insulin is highly stigmatized in the Asian diaspora, what is your view in the importance of destigmatization of the same and patient as well as community education at large?
So thank you for this question. First of all, for the genetic and the biomarker, our government has not emphasized anything yet in the guidelines. So I didn't include, and still I know it is under certain research has shown it, but in the clinical practice, we have not included yet in the routine daily clinical practice. Is also again same, we have to personalize and we have to ask the patient why and whether it will change any management or not. Because it has significant cost as well as a significant implement in the for the patient and the family members. So it has to be done quite cautiously to avoid the future problems. But why they want genetic and the biomarker, that's another thing we need to understand from the patient. So that is the answer for the first part. The second part, insulin, yes, it is highly stigmatized. So for sometimes patient need the reinforcement, so they may not understand or they may not listen to you for the indication for insulin when they come and visit you. But if they have any complication, then you can see, you have this complication and you need to start on the treatment to reduce this complication. Otherwise, you will become blind, you will lose your eyes, or you have the kidney failure and you have to be on dialysis. Will you prefer that, or you are happy to have the injection first? That's the other thing, other way I go around, because my patients, recently I have one elderly patient was not keen for insulin, HbA1c was 10. So on the screening itself, he has the microalbuminuria, he has the moderate proliferative diabetic retinopathy. Then I just told him that this can be the further consequences if you don't control. And he was okay. But sometimes the insulin, we have to ask them why they are resisting the insulin. Once a day insulin, quite often the patients are okay with that. I know the cost is the issue for the once a day insulin, but that's another thing we can push for. And it does not give the hypoglycemia, glargine, this type of insulin. So it's relatively safer and patient may go on that. But stigmatization, again, every time you have to do the counseling. And one day, probably they may understand the importance of it and they can go for that. If they don't understand, then your role is just to document that you have explained to the patient, you have informed the complication, he's accepting the worst complication, and he is still going ahead to take that risk of complication rather than to go for the treatment with the insulin. That's your documentation can help you in the future. Does this answer help you?
I hope that answers the question. Very interesting question, and more interesting is the answer. Thank you so much, doctor, for that. Do you have any other questions, participants? If there's any other question, please drop it into the chat box. And meanwhile, I'll continue to flash the attendance. So I would request, if anyone has not completed their attendance, please scan the QR code and complete your attendance. If you have any question, you can go ahead and drop it into the question box. And I would thank Dr. Pandya for this. Thank you so much. And I would also thank everyone who has attended this webinar. We'll keep on coming up with new topics henceforward. And thank you so much. With this, we'll stop here. Thank you.
Thank you, everyone. And if you have any question, please drop me email or SMS me on my mobile. I'm happy to answer. And thank you. Have a good evening. And thank you, Dr. Jayes, for organizing and arranging everything. Thank you very much.
Thank you, Dr. Pandya. Thank you.